Salam Nantehun. Peace be with you. Today I'm going to take this conversation one step further because we have a series, as you can see, related to the open love letter, which really started something. The initial responses revealed key patterns we can't ignore, and we discovered yours truly loves patterns. Um, but we know advocacy isn't just about storytelling, it's about learning and refining and ultimately building something better. I want to share 4 practical lessons that I learned as a result of understanding mom's ER experience better. And I want to pass that on to patients and their family members who might be in a similar circumstance, God forbid. But I think that it's important for us to equip ourselves with these lessons learned. So, one of the most important things someone actually within the healthcare system shared with me is that only a physician has the final authority to discharge a patient. And based on my basic research, this happens to be the case, or it seems to be the case throughout the United States, not just in the area where my family and I are located. Of course, I would encourage anyone to do their homework to make sure that that holds up in their area. Mom does remember, unfortunately, and very clearly, begging to speak with the doctor as she was getting discharged prematurely. She kept repeating over and over again, please, can I speak with the doctor? Please, may I speak with the doctor? So if you're ever in the ER and you feel like something is wrong and you're being discharged while still in severe pain, you have the right to ask to speak directly with the physician who is the one with the final authority to discharge you. Lesson number 2, if you're reporting a 10 out of 10 pain, that is so important. Bed shortages, which were cited as the reason mom was getting thrown out, they do not invalidate your pain. Your perceived pain is actually a very important clinical data point. It deserves attention, documentation, and a plan of action. If you're being discharged in severe pain, you're allowed to say, I do not feel safe leaving at this pain level. Lesson number 3, your medical information is protected. If a staff member, as in the case of this nurse, is speaking loudly about your diagnosis or your test results or your condition in a way that feels public or exposing, you have every right to say, listen, I prefer to discuss my medical information privately. Or you can say, can we please go somewhere more private where others can't hear my protected information? And that signals to the person, oh, I have to remember to lower the volume of my voice. And you're saying it in a way that's not confrontational. And it's not just about compliance either, because the facility is required to maintain the privacy of your information. It's about emotional safety, and emotional safety is so critical when you're in a vulnerable moment, as in the case of anybody at the ER. Nobody goes to the ER because, they have time left over in their day. They're there because they need care, they need help. The fourth and final lesson for the day is to document in real time. My aunt, bless her to the moon and back, was calling her sister and texting her sister, my other auntie, as mom's ER story was happening. And those time-stamped documents and recorded details made such a big difference in how we understood and processed the story afterward, and obviously how I'm acting on it now. Although I have to admit, crisis moments make it really hard to think clearly, and pain does and can affect your memory. If you can, having somebody with you is super helpful. So either you or the person with you can take notes. You can send texts to a loved one. Just capture what you can, however you can. I love voice notes. My friends know this. I send voice notes often, and that is a form of live or as close to real time as possible documentation. You can even say to any provider in sight, before I leave, I'd really like it noted in my chart that I left without my pain resolved. Or please document that I requested to speak with the doctor, not because we assume bad intent, but because clarity is really important. It protects everybody and it helps us get better, because the goal of this movement is progress. It's not perfection. So those are the 4 things that patients have control over And it's hard for me to lead with that because I believe deeply in structural reform and it's what I value and it's what I'm working towards, what I've dedicated my career to. But I also believe in practical wisdom and in empowering ourselves with what is within reach, what is reasonable and feasible for us to do right now while we wait for that slow, more sustainable structural change. Now I want to shift my focus because this isn't just about what a patient can do. You might recall again the patterns we noticed with Mom's story. And one pattern I haven't talked about yet in the last couple of weeks is that people kept saying over and over again, your mom is so kind, she's so gentle, she's so non-confrontational. And this word about mom being dove-like or being a dove kept coming up. And two people actually said to me, if this had happened to somebody really aggressive or was violent, then maybe I'd understand. But your mom? And that comment really sat with me because I never intended to suggest that only gentle patients deserve compassion. Everyone deserves compassion. And I want to be clear that I also never meant to imply that advocacy has just one correct tone. In fact, sometimes advocacy is not well received and it looks like protest, even, or it looks like tree shaking when necessary. As one of my dear friends and mentors once explained, in policy work, there are the tree shakers and the fruit makers. And you cannot bake the apple pie, if we use that as an analogy for policy or reform, unless someone shakes the tree first to get the apples. And both roles, the tree shaking and the apple making, are really important. We've noticed my style tends to be reflective and root cause oriented and shared accountability model driven. And that does not invalidate other forms of advocacy that history has proven necessary. And it would be a shame if I didn't own that during the Black History Month that became the backdrop to me finding my authentic advocacy voice. A colleague and friend sent me an article written by two Harvard scholars. Now, you're on the right track when there's Harvard scholars who have an entire philosophy and program around a matter that you believe in or that you're advocating for. And this article is titled, Does Love Have a Place in Public Policy? And while I joke about, this thing being supported by Harvard, I genuinely believe there's wisdom in all parts of the world around us. We just have to be willing to listen to it and learn from each other. But back to this article that these Harvard scholars wrote, they argue that love does have a place in public policy. And I want to tell you what stood out to me most from their article. They said, we should promote love within medicine, not only the provision of services. We should promote the provision of loving care. We should ground our economic relations in structures and norms that prioritize loving communities and relationships over short-term profits. Those, my friends, are not soft words. They are structural and they are an important call to action, because if chronic stress dehumanizes providers and that dehumanization then spills over into patients and caregivers, then restoration has to be structural. And as the saying goes, you can't pour from an empty cup. One of my closest friends said to me, it takes a very strong person to keep pouring from an empty cup with love. Some of us forget why we are where we are when we are in broken moments. And that image of an empty cup keeps almost haunting me, because we don't want to punish people who are exhausted. We want to kindly ask for a system where cups are refillable. And part of what it looks like in practice, now speaking directly to hospital executives, so I'm hoping you all are part of the audience now, it's that we hire more providers so that we can get that patient to provider ratio down, which we know is going to help prevent the provider burnout that is so well documented in research and that is contributing to these crisis moments in the healthcare environment. Another friend said something to me that I also can't shake. It's something related to parenting, actually. This friend said, as a parent, I think about repair and accountability. I hope the nurse sees your video and feels forgiveness, but also takes accountability and knows repair is still possible, much like that child parent relationship. So now we're getting into how transferable this beautiful notion of love is in all kinds of different spaces. And because repair was the heart of my initial message, it brings me joy to know that there is now a growing community of individuals who are wishing for that love and that repair work to the nurse alongside me. I am just so pleased that this work is shifting. What started as a story about one of mom's lowest healthcare moments has turned into an important conversation about trauma-informed design and care, and more importantly, about love in policy, the kind that expects better from our healthcare systems while believing that repair is possible. And if you're still here, I'd like to thank you so much. As one of my dear friends, an avid Liverpool fan, consistently says, you never walk alone. This is Alchemizing Stories, where we turn pain into purpose. Salam May your peace overflow.